A very good morning, everyone. As people are joining, we'll start with our session in another 10 minutes. Thank you.
Hello, sir.
Good morning.
Good morning, sir.
Good morning, Ambika. All the best.
Thank you so much, sir.
Ma'am, you can share your screen. We'll start in some 5 minutes because people are still joining.
Sure, sir. Yes.
Good morning, sir.
Good morning, Gupta ji.
எவ்வளோ காசு இருங்க அந்த டப்பா எடுங்க
Good morning, ma'am.
A very good morning to one and all from the East. On behalf of Department of Oral Medicine and Radiology, Institute of Dental Sciences, Shiksha O Anusandhan, deemed to be University Bhubaneswar. This is Dr. Ambika Rai, first year postgraduate trainee, and it gives me immense pleasure to be the part of the organizing team of this mega webinar series. Today we have with us our dynamic dean, Professor Dr. Neeta Mohanty Madam, a passionate teacher, an avid researcher, and the person who envisioned this series of webinars to ensure lockdowns do not pose hindrance in learning. Ma'am has a keen interest in biopsy and encourages budding dentists to train in the procedure. I now request our beloved Dean Madam to kindly welcome this august gathering. Over to you, ma'am.
A very good morning and welcome dear all to the 10th webinar of the mega webinar series organized by the Department of Oral Medicine and Radiology, Institute of Dental Sciences, Shiksha Anusandhan, deemed to be university. The topic today is biopsy, the third eye of the diagnostician, by none other than Dr. Ambika Arora Tiwari from Mumbai.
Thank you, ma'am.
Yeah, welcome, Dr. Ambika.
Thank you, ma'am.
Yeah, the topic biopsy is always close to my heart since my post-graduation days at Dr. R.M. Dental College, where doing biopsy was part of our MDS curriculum. And the difficulties one faces during performing oral biopsy has made me come up with 2 devices on oral biopsy instrument, which God willing may come up, be available in the market in 1 or 2 years. Biopsy being the gold standard of diagnosis, the pathologist not receiving the proper size and depth of the biopsy tissue may lead to erroneous diagnosis. So it's a dream of a pathologist to get a proper, to give a proper histopathological diagnosis, to get a proper size and a proper depth, which we usually do not get, apart from the clinical and radiological correlation, which we don't get most of the time. So here we are today for the 10th webinar, biopsy, and our resource person, Dr. Ambika Arora Tiwari from Mumbai, is here to speak on the topic. I'm sure it will be an enriching and learning experience for one and all here. And I truly want that every dental surgeon should perform biopsy. Every intern, apart from any department, they should be able to perform the right biopsy. It's very important for diagnosis of especially oral lesions, especially OPMDs or you say oral cancer. Thank you so much. Over to you, Dr. Ambika.
Thank you so much, ma'am.
Good morning, ma'am. Thank you so much for the opportunity to introduce the speaker for our today's webinar, Dr. Ambika Arora, ma'am. Ma'am has done her MDS in oral medicine and maxillofacial radiology from Mumbai and is consultant as oral physician in her field and has been the recipient as the winner of the prestigious FAMDEN Excellence in Dentistry Awards in December 2018, 2017 and 2016, and also the winner of Indian Health Professional Awards held in January 2017. She has been bestowed as the Oral Medicine Specialist of the Year in 2019 by IDDA. She has been the winner for Best Paper in all national conferences of her specialty right from 2014, 2015, 16, and has been bestowed by the Academic Excellence Award in 2017 and was felicitated by MUHS University College Topper. She has been numerous national and international publications to her credit. So join me in welcoming Dr. Ambika Arora, ma'am. Over to you, ma'am.
Thank you so much, Anamika. Today's topic of mine is biopsy, the third eye of a diagnostician. But before doing this, any student is known by the college which he or she passes by. I am in debt to my graduation college and my post-graduation college, that is Tena Dental College and YMT Dental College, both in Navi Mumbai. A good teacher is like a candle. It consumes itself to light the way for others. And so is my gratitude towards my guru over here, that is Dr. Deepa Das ma'am, Dr. Anil Sheth sir, Dr. Dhyan Sundaram sir, Dr. Prashant Hatkar sir, and my beloved husband. Without them, I am nothing, and definitely I look forward them. I am totally blessed to have gurus in my life, and I cherish this all throughout. I am also very thankful to the Shiksha O Anusandhan and the IDS College Bhubaneswar, Dr. Satyaranjan Mishra sir, for considering me and having the trust in me, giving me this platform to showcase what work we can do as an oral diagnosticians. I'm also indebted to AMROPIN, that is Association of Oral Maxillofacial Radiologists and Oral Physicians of India, who are working behind the scenes in order to uplift our field. Also to Indian Academy of Oral Medicine and Radiology for being so supportive to allow these forms, to uplift our field further through the webinar series. A small disclaimer to this presentation. The information in this webinar is for educational purpose, aiming to fulfill the objectives mentioned in the talk. This topic being clinical, skills need complete understanding and practical knowledge, and this lecture can be treated as a conditioning lecture for the same. Clinical case pictures are actual under Maxicare TMJ and of Parent College, and those which are not have been cited with the reference. This talk is not replacement of practical training of learning the art of biopsy. So when I said the word biopsy, this is your reaction on hearing it? Or this is what you imagine on hearing biopsy? Well, I'm sure that everyone would have doubts in their mind of who is actually supposed to do biopsy. How is it supposed to be done? When is it supposed to be done? All these queries, I'll try my best to answer through my presentation. So why an oral medicine specialist should be considered as a person resort to for doing biopsies? Are they really compatible to do these biopsies? Are they an expert in the entire field? Well, once you're going to see my cases, you will definitely understand. For your understanding, I have put those cases which I feel that when an oral diagnostician was missing in them, what the case turned out to be, and what the case would have been if an oral diagnostician would have been there in the picture. One such example is this case. Now, this is a 45-year-old male patient. As you can see, the lesion extending on his left buccal mucosa. Now, this patient had actually gone to one of the prestigious cancer institutes of India. There, they labeled it as leukoplakia. For a second opinion, he went to a surgical oncologist, and he too claimed that it to be a leukoplakia. Since there was no deleterious habit the patient presented with, the treatment for him was planned to be just a follow-up for every 3 months. Now, this is a condition, where an oral diagnostician or even the dentist were nowhere involved in this scenario. So when this patient was then referred to me by the clinic where I go as a consulting, this is the case which turned out after 1 month. So where we see a lesion which was termed as leukoplakia, and the only treatment and the management given was follow-up for every 3 months, the case within few days and after 1 month of follow-up, there's complete resolution of the case. So does that mean that the one who had seen the case are not really the ones who should see the case? The answer is not. The answer is very simple. We have a sword on one side, and on the right side, we have a knife. Both are very useful, but then their terms and conditions. They are very skillful, but in their platforms and their conditions. When we are dealing with oral lesions, it is better off to leave it to the oral diagnostician, a person who has both the medical and the dental knowledge. Coming back to the previous case, what did they miss? First thing, the biopsy which was done was sent to an MD pathologist. Nowhere am I denaming or am I defaming any pathologist in this regard. What I mean to say, if this case was sent to an oral pathologist, they would have done some correlation of why this lesion, what this lesion would have been. How does an oral diagnostician come over here? If you see the lesion carefully, I'm using a pointer. If you can see the lesion and have a nice observation in this case, can you see an amalgam filling? Can you see a metal crown placed over here? And can you see, after the treatment which I had planned, after putting in non-irritating substances in the patient's mouth, can you see the complete resolution? This was the case of Lachinoid Dysplasia. Firstly, it was not seen in the histopathological report with which the patient presented with. So here is where I'm talking about why an oral diagnostician is important. A patient of Lachinoid Dysplasia is always known that in the long run may turn into malignancy. And this patient was one such person who might have turned a malignancy, not now, but after a few years. So this is where we need to understand our skills. Yet this is another case. In 2018, one of my fellow dentists had called me for a consulting. After 1.5 months of application of topical steroids for a traumatic ulcer, which he claimed to be, this was a lesion he presented to me. Unaware of what the lesion could have been, the only complaint patient was having is reduced mouth opening and slight burning sensation. I insisted on a biopsy, which was taken as a reluctancy in the beginning because anyone would get scared with the surgical approach. So biopsy, I had to make them understand why is it necessary. And as you can see, once a biopsy was done, it turned out to be a squamous cell carcinoma. A very naive-looking lesion, which anybody these days use topical steroids thinking that it is a wonder drug. It is a wonder drug, but unless until you know where to apply and how to apply, you may do serious harm to the patient. And this is the case exactly when I dated back to literature, which I usually do after every case, I saw the following. In the year 1963, Robert et al. Had clearly mentioned that you should do a biopsy of suspicious lesion and you should immediately, or if you cannot do, then you better immediately refer it to a professional who has more experience in doing these lesions. But by no means should you wait and watch. This was the case of purely waiting and watching. I'm really indebted to Dr. Professor Neeta ma'am, who just now mentioned that it is very essential for everyone to do biopsy, be it whichever stream. If you feel that your specialization does not encompass you to do the complete biopsy, then I believe you should refer it to someone who has the experience to do so. But in this, you are going to do good to the patient. In this iatrogenic scenario, wherein a patient was having minor OSMF and maybe a traumatic lesion at that moment, it turned out to be a squamous cell carcinoma. So let us burst this myth, what should be the biopsy, who should do it, how should you do it in the following series. Since my lecture is not of that academic importance, my lecture is purely based on the clinical experiences which I have. We all have references to matter, to go to. We have our library, we have the online sources to read up the matter. But what we fail to understand is the total practice which we have in an institute is completely different when you enter a private practice field. And my today's lecture is going to correlate everything you learn in your theory lectures. How do you correlate it in your private practice? So going by the definition of biopsy, the term biopsy itself is made up of two words. Bios means living and opsy means vision. It is very well to be said that biopsy is a third eye of a diagnostician based on this. The diagnostic sequence of any pathology consists of the case history, examination, provisional diagnosis, laboratory investigations, biopsy, radiographic investigations, all leading to the final diagnosis and then the treatment plan. What is the need of biopsy? First and the foremost is for the definitive diagnosis, for which we call as the gold standard, and treatment planning, to determine the prognosis of the cases of malignancies. It also gives an indication towards how the response of tumor is to the therapy, and yet, of course, for research, record, and for the medical legal cases. To brief it up, what are the indications of biopsy? Any lesion which is not healing for a period of 2 weeks can be considered for definitive treatment, for clinical impression of any cases, for intraosseous lesions, for any abnormal tissues which are removed from oral cavity, hyperkeratotic lesions, characteristic for a malignancy, any lesion which interferes with the daily living. Because when you enter a private practice, your main focus should be on the comfort of the patient to improve the lifestyle of the patient. So this is one such indication for the biopsies. Along with this, as a personal note, I feel whenever patients these days, they are aware that there is something called as oral cancer, and they get very scared when they know that there's something in their mouth which no doctor is able to understand. biopsy comes to the rescue there. I have had patients who had seemingly non-neoplastic lesions in their mouth, but they were so scared of it being to be a neoplasm that once a biopsy was done, they had the mental peace, and definitely the lesion was also taken care of. What are the contraindications? The first and the foremost related contraindication would be a compromised general health and proximity of the lesion to any vital structure or vascular structures. An absolute contraindication would be any pulsatile lesion, pigmented lesion. Why? Because there can be a spread of melanoma through the blood-bone area. And the intraboreal lesions always should have aspiration before undergoing a biopsy. So to sum it up, the objective of a biopsy should be to confirm the diagnosis, to determine the treatment plan, for self-teaching as medical record, medical legal cases, grading the tumors, detecting receptors, for screening purpose, monitoring, and the research purpose. So, just if I have to tell you what this biopsy comprises about, it comprises of two sections. One is a surgical and other is the non-surgical. Under surgical, we have the soft tissue component and the bone component. In soft tissue, we have the diagnostic and the curative, comprising of the incisional, which has the punch, electrocautery, soft tissue curettage, frozen, even laser, excisional scalpel, cautery, also the laser. In surgical, for the bone, we have the curettage, fine aspiration, frozen, enucleation, resection, curettage, and the non-surgical comprises of the aspiration, cytology, exfoliative, FNAC. In all of these, the points which I will be covering are exclusive from the clinical point of view, which you can do on the chair side. For those which are done exclusively for other body parts or which are done not pertaining to the oral lesions, I will be giving it a skip. Also, based on the features, it can be classified as direct biopsy, indirect biopsy. Based on timing, it can be classified, and the purpose. Now, here are the various biopsy techniques. I'm sure you must be overwhelmed when you come to know that there are 23 or rather more techniques for doing a biopsy than the typical ones which we know about. I'll try to cover as much as possible which are used on day-to-day routine dentistry. So talking about incisional biopsy. An incisional biopsy is a biopsy that samples the most representative part of the lesion. To begin with, I'll be showing you further my cases so that you understand better what do I mean. Over here, this is a case having a red and white lesion on the left buccal mucosa. As you can see, because of the long span, complete resection at the first go is not appreciated. One should undergo an incisional to know what kind of lesion it is for a definitive diagnosis. As I had seen this case, I felt that there are two particular lesions which are present in the same site, and hence I chose to do two incisional biopsies rather than just one to have the most representative part of it. The second case, as you can see, again, we can see a red and white lesion, and here only one incisional biopsy was more than sufficient. In this case, the patient did not have any complaint. However, the parent doctor doing the restorative or the prosthetic rehabilitation of this patient was concerned with this lesion and wanted a biopsy just to be assured that his treatment plan is not disrupted with it. This is another case. Now, this is a case of 79 years old male patient being treated for pemphigus, as you can see. Again, this patient has he's a local worker, and he had a mere complaint of reduced mouth opening. Little did he know that he was harboring a squamous cell carcinoma in his oral cavity. And this is yet another case. Being long span, and incisional biopsy is very much essential to know the depth of the lesion and if there is any malignancy potential. What is the principle of incisional biopsy? So as I told you, that the principle lies in the most representative part. We should biopsy in a wedge format. Rather than a shallow broad, always ensure you have a deep and a narrow section. Why? Because we are interested also in the connective tissue which is present. The spinous cells, the basal cells which are present have great notation to know that what the lesion could be, whether it is a neoplastic lesion or not, and hence the diagnosis totally depends on them. A deep and a narrow biopsy is what we aim for in incisional. Never take a necrotic area as the cells in it are non-diagnostic. As you can see, when you have two or more lesions on the same side and you insist of doing two incisional biopsies, you can very well choose the most representative part and do the biopsy. As you can see, a deep, narrow, and a convergent. I will be explaining to you exactly how do you do the biopsy in the further slides. So in this case, since this was a red and white lesion, I also used an adjunct of toluidine blue stain. Why toluidine blue stains? Because I wanted to be assured that whichever sample I'm choosing are actually the sites which are the most representative and may have the dysplasia which I'm looking for. And hence, as we can see, basically, in short, if I tell you the protocol of toluidine blue staining, you ask a patient to first rinse them out with water, then 1% acetic acid, then the toluidine blue stain, and again for 1% acetic acid, and then you finally wash it off, you get such staining. Being a metachromatic dye, it ensures that being acidophilic also, the nuclear component, which is the highest, are the areas which take up the stain. However, you require skill in differentiating which are those dysplastic areas and which are like irritational areas or hyperkeratotic areas which also take up the dye, giving a false positive. This is how later on the two incisions were taken and suturing was done. It turned out to be a case of dysplasia on one side and the hyperkeratosis in the other side. Now coming to punch biopsy. Now this is an alternative technique, one of the most used techniques in biopsy and one of the most simple ones. It also leads to complete removal of the lesion, but at the same time, if you have a very big lesion, you are very sure of the diagnosis, and you know that all are comprises of the same lesion, then you can definitely do punch biopsy. One of the major perks of punch biopsy is you can do it on hard tissue, wherever you're having a hard base like a palate, or you can have on the attached gingiva, which can thereby heal by the primary intentions. As you can see this case, this was a melanoplakia case, so I intended to do the punch biopsy in this case. These are the cases of gingival enlargement, and this is a case of oral submucous fibrosis. At this point, I would like to add, being such a simple technique, which I'll be explaining now, I would request that any sort of lesion which you're not expecting any neoplasia, but definitely for diagnosis you would like to do, or for theory purpose, for research purpose, please encourage the PG students to do biopsy, especially the punch biopsy. Why? Because one, they will become fearless. Secondly, it is a comparatively harmless technique. Not much of a skill is required when we are doing the punch biopsy. As you can see, these are the dermatological side which we use the punches. These are the disposable ones. They range from 1 millimeter to 8 millimeter. And this is the autoclavable stainless steel one. Now, being from oral medicine, we have the liberty to be associated even with the medical fraternity as much as the dental fraternity. So I was lucky enough to be associated with the medical counterparts who have been doing in oral cavity biopsies, and they are using certain instruments which I too felt were very good enough to be used by us as well. One such instrument is the Lux Forceps, which they have been using, especially by the ENT counterparts. So this is used for those areas which are not easily accessible and have a sharp edge towards the tip. Typical instruments of punch biopsy used by the same fraternity is also known as a punch forceps, which is over here. So you can literally punch it, and it's very easy to do with these instruments. They are readily and easily available with any surgical place, where other surgical instruments can be procured. So this is an example wherein the orifice is being sharp. You actually put it at 90 degrees to the surface where you intend to do the biopsy. You rotate it clockwise and counterclockwise like a screw action. And at one point, you will notice that the area which you were intending to has actually popped out, separated by the other areas, delineated very clearly. And now there is just a stalk which is present, which you can do it with the scalpel, a neat, clean incision. At points where you feel that patient's oral hygiene is compromised, or you have used a bigger diameter or larger diameter punch biopsy instrument, then a small suture may be required. But when doing it with smaller diameter instrument, you don't even require a suture for that matter. Now, talking about the excisional biopsy. Excisional biopsy clearly means in toto. As you can see, one of my cases over here. Now, this was a case of 65 years old female patient having peripheral ossifying fibroma. Now, due to the restraint of time and the motive of the PPT, I really wanted to show all the cases with the radiographic presentations, but because of the time and because this is a conditioning lecture, I would rather stick to the most represented photograph of my patient. So in this case, excisional biopsy was performed. Adjoining to this is another lesion, which was a traumatic fibroma, which too was removed at the same sitting. This is another case which actually initially began with a mucosal, but due to the chronicity of it, it later on turned into a fibrotic lesion. Now this case, now when I'm talking about excisional biopsy, when concerning with a very clear-cut diagnosis, excisional biopsies are the treatment of choice. However, even if you're working with a medical counterpart, they will always vouch for one thing: never do excisional biopsy for a lesion you are suspected of a malignancy. And this was one such case. Because my provisional diagnosis were already, I was sure that this is a proliferative varicose leukoplakia. I intended not to do excisional biopsy first, although this was a short span case. I never wanted to do an excisional biopsy, and I intended for an incisional biopsy, wherein I know that what grade it was and how deep it was, and then it was followed up for a complete excisional biopsy. So the principle again lies, you do an elliptical incision. It should be deep enough to involve the lower inferior connective tissue present, and it should be converging. Now here is a trick. When you do it converging, you promote better wound healing, as you can do undermining of the lesion, which I'll be showing you. Curative biopsy is another curative meaning being cleaning. So whenever you're dealing with your intraosseous, your cystic lesions of the jaws, especially maxillary antrum, the other cystic lesions, there you can actually, after doing the enucleation or the marsupialization, you can actually curate the entire space. And these small chips which you collect of the samples, you can send it for the histopathological report. Talking about electrosurgery and laser biopsy, I have tried to club them together. The reason being, the motive seems the same. Firstly, anytime you ask a histopathologist or a cytologist that what is one thing which you will not accept in a lesion is when you do laser biopsy, there's charring of the margins. And this actually hinders the histopathological diagnosis of the case. And hence, in my personal opinion, if you feel that you want a bloodless field, you want more comfort for the patient, you don't want suturing, and in very large span cases wherein you can't do scalpel biopsy, then what I would suggest is you do the scalpel biopsy first, and then you can seal off the feeder vessels by doing an electrosurgery, or you can, for long span cases, you can do a laser biopsy. When you know that the diagnosis is very simple, it is non-neoplastic lesions, you can straight away go for laser biopsy. But when you're suspecting a malignancy, I would prefer refrain from doing laser biopsy unless until you're truly mastering the technique wherein you're not harming the margins. So this was one such case wherein the provisional diagnosis was very clear-cut, and hence I opted for the laser biopsy. Frozen section. Although this is not done as a chairside procedure, but for me to mention about this was very essential because of the importance which it lies with. A frozen section biopsy is typically for rapid microscopic analysis at the operating table. So what happens over here, the surgeon while operating the case actually removes it, the portion, to send for the frozen section immediately for the microscopic analysis. And on that moment itself, they come to know about what type of lesion it is, whether there are viable living cells, whether there are new plastic cells or not, so that immediate surgical therapeutic decisions can be taken. The clearance of the margin can be achieved at that moment, and you can ascertain whether metastatic involvement is there or not there. The greatest advantage is you're avoiding a second operation, and the entire mass and its surroundings border can be removed at the same spot. Talking about fine needle aspiration cytology. Now, this is one of the most crucial. Earlier, people were a little afraid of doing that, and they doubted the cytopathologist report on this, because it is a tough procedure. It requires skill. It cannot be as simple as a punch biopsy. However, recent research, I'll tell you about the way, the cytopathologists are not doing the reporting, such that this is one of the most preferred choice. So FNAC is also, there's a different component known as a fine needle core biopsy. Based on the diameter of the needle chosen, the two varies. Basic indications are lymph node, thyroid gland, salivary gland, cystic lesions of the neck, and the other lesions. My main motive for talking about FNAC is for the salivary glands, apart from the lymph node, which we all are aware. Why salivary glands? Incisional biopsy in a salivary gland is a little complex, leading as it leads to fistulas, it leads to fibrosis, and definitely there are chances of the tumor seeding when doing biopsy, incisional biopsy in salivary glands. So the method of choice is FNAC. Talking about FNAC and FNAB, the fine needle biopsy, there are two methods, one with aspiration, one without aspiration. Now this is an illustrative picture which you can see. So here the needle is positioned into the target area, and now a negative pressure is applied by pulling the suction behind. Okay, and then the needle is back and forth, up and downward movement is occurred, so that the cells incorporate into the hub and the needle. And once that is done, as per your judgment, you then release the negative pressure, ensuring the needle should not be out of the target. Finally, you take out the needle and the syringe out of the target area. You remove from the hub, you fill air in this, and you put it back to a hub, and then you can deposit the sample onto the slide. And without aspiration, that is a Justella technique, you don't even require syringe, which is usually 10 or 20 ml. So you just take the needle, you actually do in the rotating manner, up and downwards in different rotating angles. And finally, you would remove, attach to a syringe which is preloaded with air, and then you are going to expel the same thing on a slide. Now over here, I want to add, when dealing with FNAC, as an oral diagnostician, I would like to ensure that every oral diagnostician, whoever does these procedures, must have some background knowledge of oral pathology as well. That's because it will be very convenient for you what to expect from an oral pathologist, as well as understand what do they expect from you. So in this one such criteria, when you're going to have this smear layer, a cytopathologist is the one who would actually diagnose the smear layers on these slides. However, it was noticed that the mass architecture of the tumor cells were not very well appreciated with this technique. So what have they come up with is something called as a cell block. So what does a cell block do is when you suspend these into a media, and then there is a centrifugation of that sample, the sedimented layer is then poured with the molten agar, and there are many other ways to make the cell block, and the block is formed through which sectionings can be done and the mass architecture can be seen. Recently, they have come up with something called as a cell button technique. So what a cell button is, at this point, when you're depositing the sample onto the slide, especially of those cheesy matter, which are semi-solid sort of, they actually hold on to their dome shape when you drop it onto the slide. The slide itself needs to be fixed with 95% ethanol. And once it is fixed, it actually holds onto its shape. And after some time, you need to take a scalpel and you need to clear it from the slide and treat this as a small tissue biopsy. And then further it can be done. This was a major improvement, I would say, which I'll be showing you, as this forms the bridge between a cytopathologist and a histopathology, gaining importance and significance from both the aspects. Now, this is an aspiration gun, in order to have the negative suction, which I was talking about. Few of them use this Frenzel's handle. Causes of unsatisfactory yield, which is one of the most common failures of FNAC. The first and the foremost is you have missed a lesion. You have gone tangentially, especially in deep-seated cystic lesions. You have entered those areas which are having non-diagnostic cells like the necrotic tissue, ulcerative, or there's a dominant, you can see a benign mass, and you have missed out the malignant lesion which is just adjacent to it, or it can be a fibrotic lesion such that it doesn't yield much of the cells for diagnosis. The cell block and the cell button technique, which I was talking about, is this bridging thing between cytopathology and the histopathology. Talking about exfoliative cytology. Now, we have heard about this famous saying that never judge a book by its cover. Now, this is proved wrong when it comes to exfoliative cytology, because the basis and the principle of this is that the superficial cells which are exfoliated actually represent what exact lesion is underneath in the deeper tissues. And this form the basis of it. The armamentarium for exfoliative cytologies are pretty simple as a tongue blade to a spatula, which is used in dental instruments for the routine dentistry. You have the various forms of brush, the more branded brush being the CDX brush as seen over here. Since India is still a developing country, economy is one of the things which always comes in our mind. You will be shocked to know that even a toothbrush can yield a very good sample when dealing with exfoliative cytology, which can be spread as a smear onto this glass slide. These cytologic smears can then be classified into the 5 classes, being the normal or typical, intermediate, suggestive of cancer, or positive of cancer. Now, it is well established that DNA aneuploidy can predict malignancy prior to histopathology, and cellular morphology tends to be relatively stable than molecular markers. Thereby, it was then confirmed that cytology testing can be chosen as one of the adjuvants in cases where you're unable to take a biopsy. Now, this can be multiple because of the contraindications which I mentioned earlier, or because the patient is a little reluctant to undergo a biopsy. Then these modalities are one of the best modalities to be used as an adjunct. Now, talking about touch impression and imprint cytology. Now, this is nowhere related to chairside, but this is very much connected to the frozen section, which I spoke before. Now, in this, because frozen section is a limited amount of structure which you are setting for the microscopic analysis, in imprint cytology, you take a glass slide and you just keep sliding that glass slide over the entire margins of the resected part of the patient. Thereby, every aspect of that lesion will be captured, and you will come to know whether if there is any malignant cells still remaining in that or not. So thereby, this overcomes the limitations of the frozen biopsy which I mentioned. A very simple local technique would be a scissor biopsy. Now, these are for those lesions which you're very well aware of the provisional diagnosis. It's very well pedunculated. You're not expecting any bleeding. And you just need to hold it by the tissue forceps and just use a scissor biopsy for the same. Shape biopsy is more for the dermatological counterparts, especially on the dermis, for seborrheic keratosis and all. You actually scrape through the lesion in this using a scalpel or a razor. Coming to the assisted guided forms of biopsy. Now, biopsy, as we know, is a blind procedure. So there are times wherein a deep-seated lesion or a lesion which is very close to an important anatomical landmark, you may be afraid to do, or you may not get a better judgment. So to increase the chances of success rate, we have different modalities, beginning with the ultrasound guided biopsy. Now, this is case of FNAC being done with an ultrasound. As you can see, into the lesion, the needle punches exactly, thereby increasing the success rate of your procedure. However, those which is having gas embolizations, those cannot be really seen well on a USG. And hence, CT guided biopsy for those which are skull-based lesions, where the USG is not that useful for doing the biopsy. We have the percutaneous ways of doing CT guided. Here, as we can see, the needle is approaching from the inferior zygomatic arch process in between the condyle and the coronoid process, entering into the mass M. This was a case of a previous mastocylectomy done, and a recurrent tumor was then being formed, and hence CT-guided biopsy was a diagnostic procedure of choice for doing biopsy for this case. MRI-guided biopsy. Now, we all know oral medicine being an amazing field of not only comprising of medicine, but also maxillofacial radiology. So this is the beauty of being an oral diagnostician, that you have the perks of both the fields, the imaging modality as well as the clinical modality. in our medical counterparts, there are interventional radiologists who come into picture when we have these sort of modalities for our biopsy and for FNACs. However, in dentistry, we have an oral diagnostician, yet again proving that why they are the best choice for doing them. So in MRI guided biopsy, as a radiologist, we know that unnecessarily we should not expose the patient to ionizing radiations and all. So here is a MRI which does not expose the patient to the radiation, but yet again, for cases which are near the skull-based lesions and all, for biopsy, we can make use of it. The only disadvantage in this case is that you require an MRI compliant needle. At the same time, it is a very costly imaging affair. So as you can see, this lesion is present at the skull base. Now this is a water-filled syringe kept for localization of where exactly are you going to inject your needle. Coming to the endoscope guided biopsy. Now talking about this, for those, again, having the medical counterparts, those lesions, especially of the pharynx and all, our medical counterparts would engage using an endoscope. Why? Because of the inaccessible areas with which they can see the lesion as well as do the biopsy. So very deep-seated lesion or maybe at the base of the tongue, an endoscope is something which we can use. Now to this, I would like to add a point. As Professor Dr. Neeta Mohanty ma'am had mentioned about her patent biopsy instrument, I would like to throw a light at if ma'am can later on, maybe in the question answer round, if ma'am can just explain us about how her instrument works, because if I'm not wrong, her instrument incorporates something very similar about the fiber optic light along with the camera, and you can do the biopsy of deep-seated lesions. So if ma'am can later on explain us, as it can really turn the way we do biopsies these days. Talking about the light-based modalities of well-scope-assisted biopsy. So basically, they use the blue light in the range of 400 to 460 nanometers, and they work on the principle of autofluorescence, wherein they throw the blue light, and thereby there is green auto reflection of the normal tissue as green, whereas those tissues which are dysplastic may not reflect the same green light and may appear dark. Now, this is an excellent approach, when you are having a seemingly normal mucosa and you want success rate to be there in your biopsy. So this is, you can really, what you call as, you can really focus on that which part should I take the biopsy from, which will yield the maximum success rate. Sentinel node biopsy. Biopsy will be incomplete if sentinel node biopsy is not mentioned. Little do we know in private practice, about sentinel node biopsy, but it holds great importance when on an operating table, a person for oral squamous cell carcinoma is being treated. This is where, we, as in the previous lectures of this webinar series, Dr. Arvind sir had mentioned, we need to follow the TNM staging. As an oral diagnostician, whenever you see a patient, it is really very important that when you are dealing with malignancy cases, you must mention. And so is a counterpart of the oral pathology, that during histopathology, they also have a pathological TNM classification, which they can mention along in their report. So in sentinel node biopsy, as we can see, it is a meta-analysis actually saw that in T1, T2, N0 oral squamous cell carcinoma, an overall sensitivity of 93% was seen in these patients. In USG guided, superior clarification. So basically, in USG guided FNAC for sentinel node biopsy, it has been shown to be very superior than just a plain biopsy, not an assisted one. Also, these days, an elective neck dissection is superior as compared to therapeutic neck dissection. So sentinel node biopsy is utmost important in order to prevent, because what exactly do you mean by sentinel node? Sentinel node is basically those lymph nodes where the primary tumor cells are first going to drain. So these are the lymph nodes which, if you catch at the earlier time, you are going to do a lot good to the patient by preventing the metastasis in his system. Talking about the armamentarium of biopsy, what all instruments? Beginning with the scalpel. we have the disposable counterparts, we have the stainless steel autoclavable ones. The most common blades which are used 10, 11, 12, 15. The 15 being the most commonly used. Now, this is of very much importance, when we see, naive clinicians using, how to attach a blade, how to discard a blade. I thought of putting this slide, it was very illustrative. So this is how you're going to slip into the projection of the BP handle. So you insert it till you point a clicking at the end. In order to remove the same, you first need to disengage at the base and you need to slide it on top. So this is how you're supposed to retrieve the blade from the handle. Always use it in the pen grafts because this has the most tactile sensation when doing. The scissors which are used, for these also can be used for clipping or for cutting the tissue fragments for a cleaner picture. Also, it can be used for cutting our suture material. So these are of two types. The bigger type has the blunt variant, which can be used for undermining, and the sharp variant as seen over here. Coming to tissue forceps. Now, tissue forceps are very essential when dealing with sampling techniques and the errors of the sampling technique. Because if your chosen type of the tissue forceps is not appropriate, it may lead to errors during the histopathology. And as ma'am mentioned earlier during this thing, that how it is a dream for any histopathologist to give a perfect report to a perfect sample. So this is where the trick lies. This is the Ellis forceps and this is the Adlap's forceps. So here, as we can see, this two-tip forceps is more preferred compared to the Ellis forceps. Talking about the container and the solution. So here you have the tissue already being ready. Now, where do you are going to store it? How are you going to transport it? How are you going to send the media to the pathologist? So you require a broad-based container. Refrain from using a narrow neck container. Reason being, the biopsy sample might stick to one end and may not be dipped into the solution completely. Also, while putting in a hurry, you may try to drop these fragment outside rather than inside. So it creates a bit of panickiness. A broad base is always preferred. Coming to the solution. Now here, I wanted to add a very practical data that whenever we are dealing in private practice, as an oral diagnostician, as I mentioned, you should know every aspect from the oral pathologist point of view also in order to increase the success rate of your sampling. So what does it mean is the solution which we normally use as a fixative, there are numerous, but the one which we use is 10% neutrally buffered formalin solution. So that means that contains 4% of formaldehyde. Neutrally buffered is a keyword over here. So you just can't take a 40% formaldehyde, dilute it till the consistency, it comes for 4%, and you say, okay, I'm ready with the solution. No. The thing is, they have specific phosphate salts and other salts, for the buffering action. Thereby, it prevents the autolysis of the RBCs and also does not hinder the histopathological screening of the cellular component. Always remember, whatever is the size of your biopsy sample, 20 times should be the amount of liquid which you are going to dip it into it. If you are going to transport it to a very far off place, then ensure that you put it along with the gauze piece in this, so that even if the solution tends to drip anyway, it holds and maintains the shape and prevents the dehydration of the cells, which is very essential. Coming to suturing. So this is another point where institute-based practice is way different when you're doing a private practice. Because in an institute-based, your lesion, your research, and what outcome is it? What type of lesion it is. It is more of academic-based, for the research point of view. However, your private practice is way different. In your private practice, your utmost importance is the comfort of the patient. Your patient the comfort is the topmost thing which you should be thinking of. So using black braided silk suture, which we were using in case of institutes, do not use when you're doing in private practice. I have seen, people using, firstly, There's a poor wound healing. Unnecessarily, the patient is harassed for the next 4 days, and then they also, because of the food lodgement, it is very troublesome and painful process. Rather, by using the vicryls, by using the nylon sutures and all, definitely each suture material has their own indications. How you should use, where you should use is definitely going to be more in depth, but because of the time restraints, I'm not going in that much depth. But what I can just give you an overview is these are the suture materials of choice. Yet, of course, your cost of surgery will way beyond increase. However, the outcome of the surgery which you have is beyond comparison. You really cannot compare the beautiful post-operative healing which you achieve by these. The next is the tissue stabilization. As you can see, it is very of utmost important when doing excision, especially in this case of mucocele, how the undermining is done, how the undermining helps in tension-less wound closure. That is very essential for a proper wound healing, which I mentioned just now about the undermining. This is the same illustrative diagram for the traction sutures. This is something which we must learn. As you see in this case, a traction suture was applied for a better visibility and to immobilize the lesion so that you can take a better biopsy sample from the same. Traction sutures at times can also be left in place for helping in orientation of the sample. Now, this is one thing which we tend to forget as a clinician, but it is a oral pathologist who then have to suffer in understanding that which aspect was oriented in which manner. Because I said that in the same lesion, you can have two different diagnoses. In those cases, it's very essential to know which aspect was having which type, especially when concerned with dysplasias. Now over here, the traction can also be used in this manner. You take it, undermine it, then you suture it back. Now, details required in the pathology form. Now, this is one point wherein I wouldn't be surprised if all the oral pathologists present would agree to one point, that something which they are really, tensed with or harassed with by a clinician is when these details are not filled. See, as a clinician, as an oral diagnostician, we must understand that we need to provide information to get the correct information in return. You cannot expect a histopathological report to be so accurate if you yourself have not provided the accurate information which they need for correlation. And hence, it is my earnest request that whenever you do a biopsy, the pathology form should be of equal importance. You need to have the patient data, clinical details, medical history. Who better than an oral diagnostician can actually mention all these accurately? So this is another reason why I always say, that oral diagnosticians are one of the best choices for doing investigations. Radiographic, if you have, for example, the POF, which I mentioned earlier, you mentioned the radiographic detail that what you could see, and it will really help in histopathological reporting. If there are any provisional diagnoses, please do mention your provisional diagnosis. At times, the clinicians do not mention the diagnosis, and then when they get a very lame histopathological report, then they complain that we did not get more specific. It's a very generalized report. That's because you yourself give in a very generalized manner. Previous biopsies, if this was done, then you need to mention that. This is one such reporting method which I do for all my patients as a consultant. As you can see, all the necessary data has been mentioned. I emphasize to my oral pathologist experts to give a micro photograph with each. Why? Because one thing is I have a lot of interest in reading them. Secondly, it gives a clear diagnosis. Thirdly, think from the patient's point of view. Tomorrow, if the patient goes to, say, any other random doctor, maybe he's shifted from the town, he cannot come you for a follow-up. Later on, if there is any recurrence, and if they want to show, and if there's a photo micrograph, you don't know how good you will do for your patient. Follow-up and reporting of biopsy result to the patient. Now, this is somewhere I'm going to use the platform, for requesting all those undergraduates who are going to be future clinicians, all those specialists who are calling oral physicians into their clinic for consulting. Remember one thing, biopsy never ends with only the sample procurement. Biopsy also has a huge portion of how you're going to report it to the patient. How is your follow-up going to be? That is the entire protocol of biopsy. Your biopsy never ends just on the tissue sample day. Your biopsy would end technically when you are actually done with the reporting, post-operative things have been cleared with the patient. That is when you end. I have seen in my personal experience many a times, many good parent doctors who have been calling for consulting, they will definitely let you do the biopsy. But when it comes to reporting, it's a very casual attitude saying that, why don't you send it over through an email or through a WhatsApp, or on social media, you send it across, we will just convey to the patient. People do not understand that when you are going to break the news, the type of bond the clinician starts having from the biopsy day with the patient is way different than a parent doctor also would have, because he's the one who is going to choose from where the lesion is taken. He's going to actually treat the lesion as one, and then he's going to tell the patient, okay, I had chosen this section of your biopsy, and this is what I suspected, and this is the definitive diagnosis supporting my diagnosis. The amount of comfort the patient would have talking to the person who's done on him is way different than you just answering to the patient, okay, the doctor had done the biopsy and it seems you are having CA. This is not the way a person is supposed to break the big news to the patient. So this is a moral right of the diagnostician, of the clinician who's doing the biopsy, that please let the person speak to the patient, the report, let the person explain the report, so much work has been done. Let them also, convey the same to the patient. This is something which is very disheartening when you see in private practice that they would, separate it out, and at least knowing themselves of what they're going to talk to the patient. So coming to the special considerations in large lesions, in multiple lesions. Large lesions, the most accessible area and the most characteristic one you should take. For multiple, the most representative area from interior of the lesion is something which you must take. These are few of my cases which I have just jotted down of what you can basically do, like when should you do what you should do. So for red and white lesion, include both red and white. Always, whenever possible, take the normal tissue surrounding also in your sample. Avoid the necrotic areas. Especially in case of ulcers, avoid the superficial ulcers, necrotic areas. So when I mean by ulcers, by no means am I crediting that even for minor aphthous ulcers, one should go for a biopsy. No, it is non-diagnostic. Those are not meant for biopsy. Definitely, you should know your which are the indications, where you should do a biopsy. So definitely where you're seeing indurations, where you're seeing a chronic, long-lasting, non-healing ulcer, these are the type of ulcers we should do, not for simple ulcers which heal within 1 week. For any polypoid lesions, include the base. As I mentioned, the spinous layer, the basal layers, they are very important from histopathological diagnosis. So include the entire thing, not just the superficial aspect. For vesiculous lesions, now this was another case of mine of pemphigoid. So ensure that if possible, fluid-filled lesions, the bullas, intact one, you must take it for better diagnosis. Lichen plan is the most representative area, along with the surrounding normal areas should also be incorporated. Case of leukoplakia, as I mentioned, you can use the adjuvants, you can use the toluidine glue, you can use a well scope, have the more dysplastic areas first analyzed with you, and then, remove the specimen. Mucoceles, careful excision. Why? Because if you're not excising it properly, chances are very high you may have a recurrent rate of the same. Granulomatous lesions, along with deep incisional, also have a fresh sample for the microbiology if you are suspecting an infectious agent in that. Do not cut into a pigment. Avoid vascular lesions because you never know if you'll be able to, control the hemorrhage thereafter. Errors during surgical removal of biopsy specimen. The most frequent error, injection. Now, if you're going to anesthetize a patient, definitely, please do not inject directly into the lesion, but in the periphery. Reason being, you are going to separate the cells from the lesion and you're going to distort them. Handling the forceps, as I mentioned about the Aries forceps and the other forceps, which you must use the cautery, the margins, laser, charring, all these I have mentioned. Selection of the size, what usually they say 0.5 to 1 centimeter are the minimum sizes for a biopsy which you should send. Anything smaller than that, it either has to be too representative or it will be non-diagnostic. Tissue artifacts can be clinical application of chemicals. The major reason why you should ask for the chemical agents from your oral pathologist rather than preparing yourself without knowing, what ingredients are of it. Local injections can have any interactions, surgical sectioning of it, excessive heat, freezing, mishandling of the improper fixation, faulty tissue processing, improper staining. Complications. Depending on how there can be a serious problem. Infection, so definitely you should have a sterile armamentarium. Poor wound healing. Now, if you're going to take care of the undermining of the lesions, tensionless wound closure, the type of suture material, you're not going to face these problems. Spread of the tumor cells. Talking about this, I would say when it comes to FNAC, studies have shown that depending on the bore or the diameter of the needle, every time by units of 2, if you increase the diameter of the needle, 60 times are the chances when you're going to lead to spread of tumor cells. Now, this is not the case when you do with incisional biopsies. Very rarely have they seen blood-bone metastasis due to a biopsy. It is very rare. Others can be post-operative pain, paresthesia, swelling. I'm sure that post-operative instructions are very similar to the extraction instructions which you give to the patient. So then now the question comes, how to obtain good biopsy? First thing is the site selection and the handling specimen. I'm sure that the instrument which Dr. Neeta ma'am have patented, it's going to help for the best of the site selection and handling of the instrument, which the type of patency she's getting for her instrument. We are really very keen to see that. And talking about careful selecting the area so that you don't have to repeat the biopsy. Now, this is one more thing. Out of enthusiasm, you may do a biopsy. Then you come to know that it is non-diagnostic. You again ask the patient to undergo a biopsy. It's, as I said, in private practice, the comfort of the patient is of utmost importance. And not only the comfort, how much time lapse are you taking, because the more earlier the diagnosis is, the better is the prognosis of the disease. It has been said that earlier diagnosis of a pre-malignant lesion, of a malignancy rather, ensures 80% survival rate chances. So that is the importance of an oral diagnostication, you can imagine. The deep sections are preferred over shallow, I've explained. Surface center of the lesion should be avoided. Contamination should be avoided. Infiltration of the LA should be slow and far away from the lesion. Hemostasis, manipulation, grasping, which I mentioned about the forceps, orientation of the specimen, the fixation. Tissue should never be placed on cotton, gauze piece paper. Reason being, it causes dehydration of the cells and the cell morphology would actually change. The temperature labeling of the specimen has to be taken care of. I'm sure after entire series which I have explained in a very rapid fire manner, this should not become like those online lectures wherein you can see how the basic life support is being given. So I'm sure that this is just like a primer lecture. This is nowhere asking you all that you all can become an expert on day one self. Talking about my favorite part, code of ethics. Now, this is something I was looking forward at this platform, wherein all the specialities, all the undergraduates who are going to be our future clinicians are at the same platform. As an oral clinician, oral diagnostician, and an oral physician, what does the code of ethic mean? Biopsy, as we know, is being done by a clinician. Okay. Now, as I showed you earlier, the first patient who was misdiagnosed because the pathology report was not sent to the right person because the correlation between the dental materials was not done. This would have been avoided if the biopsy would have sent to an oral pathologist. When I'm talking about private practice, it is way different than an institute. So when in private practice, you're seeing any biopsy cases, and when you want to send it for the pathological reporting, it is my request to the fellow clinicians, please avoid sending those. If you have any contacts in dental college, do not send it to the labs of a dental college, which is already functioning for the dental fraternity, for the college fraternity. Send it to those oral pathologists who are having their own lab. Their way, you are going to support them. At the same time, they are going to prosper their field of oral pathology and are going to be expertise, as I mentioned, about the sword and the knife. They are going to expertise in their field. Now, if you're not going to send the biopsy to an oral pathologist, and rather if you send it to an MD pathologist, or you're going to send it to a college because of the low cost incurred, you are actually not giving much of the work, So it's the entire degree fee is, to sustain a living for that matter. Now, this is where they end up going to clinics and doing biopsies for themselves. Now, here, as I said, code of ethics. A clinician is a clinician. So let the clinician do the biopsy. Now, if a person can do biopsies of small lesions, very well and good, because there are many lesions. We do not want that you call a oral physician for every small lesion which you see. But when you're suspecting of oral cancer, at least be assured to call an expert of that field. So that is where the ethics lies of whom are you referring to. Because in one of the cases which I showed you earlier, as mentioned in 1963, if you can do a biopsy, well and do. If you can't do, you refer. But never do wait and watch by just doing topical management, because few drugs. So that is one thing. Another thing of code of ethics I would like to know, that when you are calling a physician for your biopsy, ensure that at least the reporting aspect, speaking it out to the patient, is also done by that clinician, because that is a moral right of doing. Always remember, you follow the ethics, the morals will come following. What is a moral duty of a doctor? A moral duty of the doctor is the safeguarding patient's health. Safeguarding, not rendering the patient to later form a lesion. The most common thing I can say is, despite so many advances, despite so much of research technology, why is it that we are facing an increment in oral cancer cases by 114 and 112%, despite in the new age era which we are living in? The reason is we are having the missing link. We are having a missing link of an oral diagnostician who actually captures the dysplasia at the very instinct, without letting you let the patient wait and watch and then develop into oral cancer and then visit the institute. Because I know that definitely all doctors would never mean that to a patient. However, because you are not being aware of a stream which can diagnose as an initial level, you are actually letting go a pre-malignancy develop into a malignancy. So this is what I would expect from the code of ethics. I apologize that at a very young age I have been very vocal about it, but trust me, when you enter into private practice and you see what is happening with the patients, you really feel for them. And this is why I chose this platform, to be very vocal about it. These have been my references. I would like to thank Dr. Satyaranjan Mishra sir, that he actually had the trust and he gave that opportunity to me to present over my cases at a very young, because compared to all the speakers, I am really humble and obliged that he has given me this platform, because I really look forward to all the legends which have presented over here, and definitely to Imprint, who have been working hard way for uplifting our field. I would extend my help to all those recent pass out or to those postgraduates who want to practice these things but are facing difficulties, because whatever cases I showed you, don't go by the glamorous quotient of it. There have been many failures underneath them. So if they want to learn from my experiences, I'm overwhelmed, to help them out. And these are my contact details for the same. With this, I would like to end my session.
Thank you so much, ma'am, for this very informative and amazing session. Now, with your permission, we would like to go ahead with our question answer session.
Yes, sure.
The very first question from Dr. Mrityunjay is, what to use as disinfectant in the oral cavity before biopsy?
The betadine solution, povidone betadine solution, or the beta rinses, they are the best. You can just swipe that area intraorally also and extraorally also, if you're feeling that extraoral contacts will be there. And you can prepare this, we call as preparing the patient. You prepare the patient before the surgery.
Thank you, ma'am. The next question again by Dr. Mrityunjay is, how do we do a biopsy without possibly seeding the malignant cells?
Okay, when you're choosing about incisional biopsy, I'll be talking about a salivary gland biopsy, but incisional biopsy, tumor seeding is very, very rare. What they have seen in literature till now. In fact, the blood-bone metastasis has been very rare. Unless until there has been a blood dysplasias already. One can be really very cool-minded while doing the incisional biopsy. When concerned with salivary gland tumors, FNAC is the choice because you are not going to expose that much for the tumor seeding.
Thank you, ma'am. The next question is, do we do biopsy before or after CT or MRI for suspicious malignant lesions?
I would prefer to do it after, once you have the radiographic analysis of the same, because you have the soft tissue, hard tissue component, all the matter is there in front of you then. So you can plan your biopsy. So definitely after.
Thank you, ma'am. The next question is by Dr. Uday. What could be possible complications of biopsy and how to manage it?
See, the most common complication would be very similar to the one which we have post-extraction. So when you have a traumatic extraction of a patient, whatever complications you see, trismus, hematoma formation, poor wound healing, they are all parts of the biopsy. Even if your suture has not been tied properly, because again, suturing is a very important skill to be learned in biopsy, because biopsy specimens are very small. So how you're suturing, because many times while suturing, you may actually create more fragile areas by puncturing the lesion again and again. So that art needs to be done. But all the complications are similar to what a tooth extraction would be, and you need to follow the same, instructions to the patient.
Thank you, ma'am. Next question is by Dr. Ruchika, ma'am. If a lesion regresses completely and reappears again after a few months, like oral lichen